So basically, this is podcast number 1, and we were planning on doing a podcast last week, Jen, and everybody bailed. But I'm excited because I think this is gonna be better with me and you. There was like 2 other people, but I think just 2 people is gonna be good. So Umu,
Tell me the name of your podcast. I was just like, yes, I'm coming. So tell me the name.
that's true.
I'm excited to be where you are. So I was like, yes.
It's called For the Caregiver.
For the caregiver.
FTC. And the logo is actually going to be the coolest part of the whole thing. But
I love it.
So basically, my goal is to bring awareness to what mental health struggles caregivers endure. And because the healthcare industry has such a reputable reputation for being strong, and it always has like this face of like strength and endurance, and I think that a lot of providers are falling through the cracks of what we're supposed to look like, and we're just human at the end of the day.
Yeah, that strong black woman narrative until
Right.
you can barely get yourself off the ground.
Right.
Okay.
Right.
Yeah.
But strong face all the time.
All the time. Yeah.
So Junior.
I'm going to end up kissing the mic.
You are.
Yes.
But anyways, this is Umu Benjamin. She is a psychiatric mental health nurse practitioner. She is my OG work spouse, side piece, love of my life. Thank you so much.
I truly appreciate being here, and I really value what you are bringing to the community. There's a lot of times we have these conversations of what needs to happen in healthcare and the changes that needs to happen in healthcare, and you are moving that forward. So I am excited to be part of this journey, and in any way, shape, or form I can support. I'm here.
Thank you. Thank you. So what were we talking about 5-10 minutes ago?
Yes, physician, healthcare providers, caregiver, burned out.
Compassion fatigue.
Yes.
Secondary trauma.
Yes.
Yeah.
So I guess the concept was, or the idea you wanted to discuss was, what has been the impact on mental health due to the pandemic, COVID pandemic, on healthcare givers or healthcare providers.
And you're actually seeing healthcare providers in your practice. You're treating them. What are their complaints? What is going on with them? What are they finding difficult?
So it's sometimes very easy where we almost get to not imagine healthcare providers being what will be humans, right? Because we are supposed to have that superpower. We're always on the go. We're there to save people, but they're everyday humans, which means when the COVID happened, a lot of people going home actually were unable to connect with their families, fear of kind of contamination. What if I don't make it? What if I get myself infected? So we saw a lot of those increasing anxieties while still performing the job, by the way. We also saw a lot of fatigue, a lot of depression, a lot of panic, because at the end of the day, you were almost on your feet in excess overdrive, having to provide care, but you are not truly getting care for yourself, because by the time you come home, you are now having to have an extra isolation than whatever you were dealing with in the hospital.
Yeah.
Right. So we saw what will be a escalation of their wellness becoming actually more of a decline. So there was a lot of that we saw. We also saw an increase in substance use, right? People says, I just needed to have a glass or 2 or 3 of alcohol at the end of the night. And unconsciously, that became one that was just a coping skill.
Yes.
Yeah.
So many of our colleagues, we talk about it openly, how easy it was to consume alcohol is probably the main like acceptable one, right?
Correct.
Like, yeah, I can go home and have a normal glass or 2 of wine, and that would have been my life before COVID. And then now I'm finding that like people are saying like, I have 1 bottle, 1.5 bottles, and they come to the end of this thing, which is not the end. It's not anywhere near the end, but they're coming to realize like, okay, now I have a problem.
Yeah.
Like now I have a serious problem.
Yeah.
And none of my actual underlying issues are fixed.
That's correct.
And so I think with managing a group of people that are constantly witnessing the worst day of other people's lives, right? Because like when you're in the ER, when you're in critical care, when you're doing things, you're constantly witnessing the worst day of someone else's life.
Yeah.
And it is a secondary trauma. And yet at the same time, you don't even feel entitled enough to grieve it because it's not my life.
Correct.
It's not my trauma. I can't stand at the bedside and fall apart with you. I have to be strong for you over and over and over again. And it's not to diminish like PTSD from like a war or whatever, but healthcare is a lifelong career. You don't do a year somewhere, tour somewhere, come home, and then, you know, possibly get help and heal.
Correct.
You have to keep going back.
Correct.
You have to keep going in there day after day after day, accumulating trauma after trauma after trauma. And one of two things happen. You fall apart, or you build walls that become so thick and so huge that you can't give compassion to anyone. Correct. You can't extend empathy to anyone. You can't ever put yourself in someone else's position. And so the narrative in your mind changes from being a compassionate caregiver to, oh, well, they didn't get the COVID vaccine, they deserve to die. Or, oh, well, they smoked for 50 years, so they deserve to have lung cancer. Or, oh, whatever. And you start to build these walls around the care that you're giving others so that it can't impact you.
But you also, a lot of us also get guilt. Right? Guilt over the fact that we see things, experience things, and we are not able to almost 100% fix it.
Yeah.
And sometimes we work hard, but when we almost feel like the end product of that working hard was one that was a life lost, as much as we may not be able to express our grief with the family because we have to always have that face, that presentation of being there, but not experiencing that emotion. We tend to almost internalize that. So we then see those as an impact that now impacts us personally, ourselves, our families, and any aspect of what we feel is called safe, right? Because you almost seeing this aspect of things happening every day. And some days you kind of come into a feeling like you won. But the days that you did not win, there's an aspect of self-guilt that we assigned ourselves. And we saw a lot of that during COVID, right? A lot of the providers that would have been doing such a wonderful job, but the outcome was one that was just death after death after death. And I saw people literally shedding their skin, trying to figure out how do I process that. But there was no support. It was just go to the next room because your duty is now the next room. Yeah. And the next room most likely needs you too. But there wasn't a period where you were allowed to break, process, feel, express. So the impact of healthcare, you're 100% right. It's not an acute. We are actually functioning in an aspect of over severe stress, chronic stress. And naturally, you know what that does to the body. Cortisol levels are up. Your blood glucose levels are up. Your blood pressure is up. So what do we see as a result? A lot of people with health, medical problems as a result.
Chronic inflammation.
Chronic.
In the body.
In the body. In the mind.
Because everything is constantly on high alert.
100%. So you go from actually having that little bit of response, cortisol comes in, your body produces epinephrine or norepinephrine, right? So you are now having that energy to go, go. But that increase in that aspect of your sympathetic system now does not give way for you to learn how to kind of tap into your parasympathetic.
Right.
So now,
so what I'm going to do when I come home, all amped up,
Yes.
which I should be exhausted because I've been on my feet for 13 hours.
Exactly.
But what I'm going to do is I'm going to drink a half a bottle of wine to try and calm down. And I'm going to mess up all my gamma glutamate levels and exacerbate my problem.
And you don't have the energy though to exercise because remember, it's a different type of energy.
Right?
You just want an escape. You haven't had a point to escape. So we talk about this aspect of chronic stress, but also compassion fatigue. If you've been a nurse for 1 year, you've had your share of compassion fatigue. When you're a nurse for 15 plus years, you have accumulated years of everybody's emotions and aspect of what they're going through, and you having to be that person that holds their hands.
Yeah.
So
and years of the guilt, the accumulation of the guilt. And I think a lot of times we're just trying to turn that off. Like that's the piece we're trying to turn off is like you get to a point where you're like, we can't save everybody. Yeah. So I'm going to stop caring
But
because
yeah,
I want to stop hurting,
correct.
you know?
And that's you 100% having a maladaptive coping now, because your
Mm,
psyche is saying, I'm in overdrive.
mhm,
I don't know exactly how to fix it. I do not have the help to fix it. So I'm just going to dull it by acting like it's just part of life.
mhm,
And that's what happens, right? We kind of almost say, this is just part of life. Some people live, some
mhm,
people die. But in reality, if you look back at when we first started, we did not accept that as part of life, right? We
mhm.
felt this should not be the case. We
Right.
wanted proper staffing, we wanted proper
Right.
support.
Right. I went into this thinking that I would have everything I needed to be able to provide the best care that I could provide
Correct.
to the patient. And over the years and years, and this is where that, I know it's multi-layered, but this is where that component of what industrialized healthcare has done,
Correct.
that like, so there's the aspect of the care that I can't give to my patient, but then when you start to get into this industry for a long time and you realize a lot of the reasons why,
Exactly.
you start to feel defeated. It's almost like you come in and you're like, I'm going to be the change, you know? And then
Yes.
you realize you're in a system where no person that is at a bedside clinical level
Correct.
could be the change.
Correct. It all comes trickling down.
Mm-hmm.
Mm-hmm.
And so you can start to feel really hopeless,
Yeah.
and then your job becomes mundane. Okay, so I'm going to go through the motions. We're going to work within the system that's provided for me here, and we know it's crappy, and we know that people are falling through the cracks, and we know that, and like, we could even, like, don't even get me started on mental health patients, the backlash from COVID, and the amount of patients that were boarding in the emergency department that don't have anywhere to go.
Exactly.
Um,
It's been years of, it's been years in the making. Did not happen overnight.
right.
COVID just
Exposed.
exposed it, right?
Mhm.
And the sad thing is, Ebola also exposed it, but nobody was paying attention then either. SARS exposed it,
Mhm.
nobody was paying
Mhm.
attention then either. These were the opportunities for healthcare to change how the system works, right? Which is proper staffing,
Mhm.
more support for your staff that are doing high impact stress work
Mhm.
and manual labor too.
Yeah.
But nobody tapped into that. It was more about, let's figure out how to keep profit on board. And if we cannot keep profit, we're gonna like literally combine all this department under one person, limited physicians, limited staffing. Let's just get things working. They're very strong. They can handle it. And
Yeah.
a lot of us kind of went into that
Yeah.
mentality.
And plus, I gave you a t-shirt that says you're a healthcare hero.
Yes.
And I put up a sign that says healthcare heroes. And I
Yes.
played on the psychology of you believing that your profession is your calling.
Correct.
And you believing that your profession is what you were created to do, to give compassion.
Correct.
And so, as opposed to spending money on things that actually would apply to care at the bedside, I spent money on affirming
Yeah.
that you were going to stay in your position.
Yeah.
And I think that there is a huge psychological aspect to the way that healthcare providers, especially bedside clinicians,
Yeah.
are used within the industry of healthcare. And I'm talking about physicians as well. Like, they're just at a higher level pay of being used,
Correct.
but it's the same.
Yeah.
We bear all the responsibility. If
Correct.
something goes wrong at the bedside,
Correct.
it's going to be the nurse that administered that medication. It's going to be the doctor that ordered it. It's
Yeah.
going to be the people that were closest to the patient
Correct.
that are assuming the most risk and making the least amount of profit.
But I mean, think about it, right? We went from having, I'm not an old nurse. 15 years in, we can almost imagine what nursing used to be back then. The number of patients one physician will have in a day,
Yeah.
or a number of patients a nurse will have in a
In a
day.
day, in a 12-hour shift.
It's
Yeah.
just impossible to be able to truly be able to now do what's really true wellness when you are almost stretched thin. And they're still doing it though. We're working hard.
Do we even know what true wellness is? This might be a conversation
No,
for
we don't.
another time.
That's
but
another
like,
conversation.
yeah, true wellness is something that most healthcare providers are not experiencing in their own lives, wouldn't recognize it, wouldn't be able to give it out.
The miseducation of wellness is what we have as a culture.
Mhm.
The miseducation of what healthcare is supposed to be is what we have as a culture. The reprogramming of healthcare providers to almost learn to almost ignore or accept what is the current situation we work in is one that's been really heavily done
Yeah.
with all the aspect of the narrative around white coats, saving lives, the
Mm-hmm.
stethoscopes.
Mm-hmm.
Those are all symbols. But keep in mind, we all came into the profession because we wanted to make change in people's life, right?
Right.
And we did that, and we're still doing it. But
Mm-hmm.
there's an aspect that you step away now and you feel not so great because
Mm-hmm.
it's not moving things forward. We are actually still stagnant.
Right. Like, we do that because of the bond and the connection and the whatevers that we create at the bedside. So we are able to get somewhat of a return for our investment.
Yeah.
But not all the time.
Mm-hmm.
And not at the rate that it should be.
Mm-hmm.
Like a couple of days ago, I had a 28-year-old male who came in for mild shortness of breath. Thought he had COVID, and he turns out he has a mass in his lungs and lymphoma out throughout his body. And that's the worst day of his life.
Yeah.
And I did not have more than 9 minutes to spend at his bedside talking about that with him. Like, he is weeping in the bed,
Yeah.
and I am like borderline. Like you're 28 years old. I get it. This is a big deal, and I need to go hang blood in another room, and I need to go get this possible head bleed to CAT scan, and I need to go.
You
Like,
cannot
I
be
need
present.
to go, and there's no one else to take my place. The
Correct.
staffing is not there.
Correct.
And this is not a facility issue. This is a nationwide
Wide
issue.
Yes, 100%. We healthcare values themselves being healthcare, but how do you provide healthcare for the people who provide healthcare for this population, right?
Right.
How do you give them wellness?
How do you care for the caregiver?
How do you care for the caregiver? That's the correct word.
Right.
In times like what you just experienced, that was a time or the opportunity where we could have easily say, let's have somebody just assign to your
Right.
work load, right?
Right.
Or how would you say your patient load?
Yeah.
So you can now sit with your patient and help him process. That's part of wellness.
Right.
And we used to do that. We never had time, but we will figure out a way to squeeze it. But now we don't even have
We can't.
any more time.
We literally don't. And I mean, that gets into the fringes of patient safety and other things like that. Obviously, short staffing affects all of those things.
Guilt.
But yeah, like you feel so responsible. You feel this heavy responsibility to not only provide emotional care, but keep your patient safe.
Correct.
And yet it's almost like you're always at the edge of not actually being able to.
Correct. Correct.
Because you can't be everywhere at once.
No, you can't.
And the physician can't be everywhere at once.
Mm-hmm.
And it's an emergency room. So there's several emergencies going on at once.
100%. And
So-
at that point in time, compassion fatigue kicks in. But now you're doing a code in the next room while you're still doing the code and you're saving one person, but your mind is still saying, I left that other person unable to really.
Yes. And when I go to bed at night,
Yes.
I lay there and I think, oh, did I do this? Did I get this? Did I circle back with that person? Was I able to like close the loop in that? Like, did they get what they needed?
Mm-hmm.
And it's not always the case.
But that's where the mental health comes in.
Yeah.
Instead of you now coming home and being able to be present in your own space, you are now processing everything that could have, should have been, and it's not in our control. I do love the hospitals where they get to say, we are going to have services available to you, and it's a chaplain. That's a disservice to a huge diversity of people.
Absolutely.
I love my chaplains. They do a wonderful job.
Right.
However, we need to be able to have more of a healthcare, mental health services, right?
Right.
Or mental health counselors readily available. But even then, are they going to even allow you to take the time when most nurses or even physicians cannot even take a break?
Right.
The lunches are not their lunches anyway.
No.
So how are you even going to have mental health services available and say, we have it, but how are they going to utilize it?
Right.
One, it's missing. Two, they don't give us the time to really be able to use it. So there's a huge, how would you say, hypocrisy about wellness, right? But it's not being given to the ones that's giving or trying to give other wellness.
So true. That's such a good insight, because even if it's like without the access, every staff meeting you ever go to, they talk about all these strategies of accomplishing whatever, but the elephant in the room is staffing. Every single time. And so you could provide a mental health counselor for healthcare providers. I wouldn't have. Yesterday, I was assaulted by a patient. They threw their whole lunch tray at me. It was all over my scrubs, whatever. They come out, they're like, "What do you need?" And my mind is like, well, I need a new pair of scrubs to keep going, you know, because I have apple juice all over me now. And so it's like, that's not all that I needed in that moment. But the mentality is, what do you need to keep going?
But think about it.
And stay in this moment. So even if we had the provisions of mental health care, even if we had the provisions of therapy, when am I going to find the time to do it?
Let's step back. As a new nurse, when you were first assaulted, what happens? You're vibrating, you are anxious, your eyes are dilated, you're scared for your safety, and you're wondering, do I walk back in there? So your response is one that is now I'm
12 years old, right?
I am used to this aspect and it's part of my everyday. So such a conditioning, unconscious conditioning of what is meant. What do?
Right.
You're saying, let me just find a scrub, let me go to the next person.
Right.
No time to process.
None. And the thought of processing didn't even cross my mind.
Exactly.
And that's where they kind of want you.
That's where we are. and that's what keeps we keep people where we need to keep them. We keep them sick. We keep them unhealthy. We keep them with a narrative of you are wonderful, you are great. But the truth of it is, yes, we're wonderful, we are great. But our working conditions are not wonderful and great. It impacts who we get to touch, the lives we want to save, and it impacts us and our families as well. That's the reason now we have shortage. Nursing is not in shortage, by the way. We are the largest profession ever. But a lot of us are removing ourselves from bedside.
Yeah.
Because we are now choosing what will be aspect of wellness over not so much wellness. And it doesn't mean we don't value the care we bring to our patients or the contribution we give to the communities. But at the end of the day, some of us have to decide, do we continue that pathway to self-destruction or do we take time and space to step away?
Yeah. And I think the conditioning goes so far back. Even the ideal and the concept of 12-hour shifts was created during a time where if you went into nursing as a female, and only females did at the time, you were saying I wasn't going to have a family. It was almost synonymous with like being a nun. If you like, when you see those like old like Call the Midwife shows or whatever, and then one of them gets pregnant, has a baby, it's like, oh well, you're going to stop being a nurse now because you can't dedicate your life to this. And so we still have all these like archaic things in place of like, here's 12-hour shifts. Well, like there's been a million things published that medical errors start at hour 8 and 9.
Yes.
In a 12-hour shift from 7 to 7.
Yeah.
That 4 p.m. to 6 p.m. window is when the most medical errors get made because we weren't built to work for and think critically for 12 hours straight.
Yeah.
And yet we still have these archaic things because it saves people money.
But think about it also. Your body actually tells you it's time for shutdown. You are fatigued, you dull, you dragging. So what do?
I go to a Monster. I go get a Monster.
A Monster. Or you almost get to say who wants that, who's having something that's exciting that's happening. Let me come and help.
Right.
Unconsciously.
You know what I need is a good code right now to just really start like
so sad.
So sad. I need an adrenaline spike.
Exactly.
I'm getting tired.
That's how you reprogram yourself.
Yeah.
So we automatically, almost unconsciously learn how to notice when our energy is now done and we know how to kind of say we're going to rejuvenate it. But that's why when we're driving to go into our car, we're all dragging. And by the time you come home, then that cortisol level is now in surge.
Yeah.
So you're really not settling. You're not sleeping. You're irritable. You're fatigued, but you're not really tired.
I'm exhausted, but I'm not sleepy.
You're not sleeping. So then what happens with mental health? Insomnia, irritability, anxiety, depression. That's just the mental health aspect, not to even talk about the physical medical health aspect to it.
Yeah.
The lack of connection, right?
Yeah.
You've worked all day, you've been on your feet all day. You have families at home and you are still not going to be present at that time.
No. Yeah.
So imagine doing that day after day after day after day, years after years after years after years. So the system itself is one that needs fixing. Uh,
And I feel like we've just been talking about this for ever.
mhm.
For a long time. I mean, for as long as I've been in nursing, this is my 12th year of being an RN. Prior to that, I was a CNA. I became a CNA when I was 16.
Yeah.
I started wiping asses at 16
And we
years old
loved every
in
minute
a
of
nursing
it.
home. And I thought I was the shit, I was like, here I am. I'm working in an Alzheimer's and dementia unit.
Yes.
And I am going to change
I
the
can
world.
do this
I can do
in
this.
no time. Yes.
One ass wipe at a time, right?
Yes.
And we've been talking about this since then.
Yeah.
And I don't know what the solution is. I literally lay in my bed at night and I think to myself, like, wait a second. Like, we're the providers.
Yes, we are.
We're the doctors. We're the nurses. We're the psychiatrists. When can we, not to sound like I'm trying to start a revolution, but like I kind of maybe am, but like when can we take our profession back? Like when and how and what does that look like? Because most CEOs of a healthcare organization, I've done a lot of research lately,
Have
no medical background whatsoever, have no clinical background whatsoever. They went the route of, what's it called? Healthcare
business administration.
Business and healthcare administration.
Yeah.
And I understand that there's an aspect of healthcare that has to be managed like a business. Like
Yes.
their funds have to be exchanged. But at the same time, I don't think that it should be to the exclusion of practitioners who know what the actual business is all about. And that's kind of like, for me, I'm like, at what point do we say, like, stop talking about, oh my gosh, this sucks, and like start taking back what belongs to us?
So what has happened over the generation with healthcare has been where the brilliant of mind, and I cannot pronounce word correctly and I'm okay with that, but a lot of the brilliant nurses that were change makers have been discouraged into just being able to have a voice.
Right.
So a lot of them has almost find ways to exit the aspect of the profession and moving into bigger, better things. Over the last 10 years, we have now seen more CEOs being nurses or nurse as a primary profession going into CEOs. But by the time they go into those levels, a lot of them almost forget what it's like to be at that level. And they're now catering to what is the corporate standards, right? So which means it doesn't support us. So even though they may be brilliant in what they may want to bring, they have to minimize.
They're forced to conform to the system that they're within.
100%.
It's like systemic racism. You might have a good person that wants to go in and be a great cop, and then they're brainwashed into this system that is contrary to that. And it's like, oh, like, like everything has to come apart. Everything has to break apart.
We can sell the narrative that our CEOs are nurses. They are the foundation of the healthcare system.
We can make it look good.
So the narrative is always there. We, the bottom bedside nurses, we're proud to follow that narrative. But in reality, none of what is being promised for what is needing to be done to support us, so we can support our client or patient, is being given. But for some reason, the narrative
But
is
it's
so
like,
strong.
hush, nurse at the bedside. I'm a nurse too. I know what you're talking about.
know
This
what
is
you're
this. I did that. This is the job you need to do because these are the rigors that I grow. And I think when you look at it, physicians in the United States have the highest rates of suicide.
Where is the statistics for nurses, though?
No, they're right underneath of it. They're underreported.
Yeah.
That's another thing. So nurses have double the amount of depression.
Yeah.
This is reported.
Oh, yeah.
This is what's
Oh,
reported.
yeah. Oh,
And we've been conditioned not to report, right?
yeah.
We've been conditioned to be
Stigmatized.
Stigmatized.
Right? We're not allowed to seek out help. So we can go into this. I mean, so there's such a huge layers of this.
If what is being reported is double than what the rest of the population is actually reporting, I am so curious to know what the actual real numbers are.
Most likely triple times, 4 times, 5, 6, 7. I mean,
and I will be the first to tell you that, like, after a hard shift and there's a train going by, the thought of, I don't know, driving my car out in front of it has run through my head a lot of times.
Yes.
Like, there are so many things that are happening within the container of a bedside clinician
Mhm.
that are not being talked about, are not even allowed to be talked about.
Yeah.
And if you do talk about it, well, maybe this profession is
It's
like
not for
it's not
you.
for you. You're just kind of
Yeah.
maybe not strong enough to handle it.
Correct.
I remember having a moment with a hospitalist nurse practitioner a couple years ago after a mother I we stopped CPR on a baby, and the mother took my hands. She grabbed my hands and put them back on her baby's chest, and she
Yeah.
was like, "Please,
Yeah.
like, please keep
Yeah.
going. Like, don't
Stop.
stop."
Yeah.
And I mean, we had
What
run
do you
this
do with
code for
that?
an hour. Like, she's gone.
Yeah.
And I remember being tearful. I wasn't
Yeah.
even like, I hadn't even fallen apart. It wasn't like any of that. I was just tearful.
Correct.
And I brought this to another nurse practitioner, and she looked at me and she goes, "You need walls, baby."
Mm.
And I just think that when you see a baby pass away, you should feel sad.
Mhm. You go back to your kids. You go back to your nieces, your nephew. You
Y-
you
y-
see you see
You
yourself.
should feel a connection with the other
Yeah.
humans in the
Yeah.
room that have experienced the
Yeah.
biggest loss of
In
their
their
life.
lives. Yeah. Yeah.
Like, that should be allowed.
100%. But part of the retraining and the exposure is one that you almost get to act as if this is just another day, another work,
Yeah.
another life.
Well, nothing you can do about it. People
And
die, right?
yeah.
Shit happens.
But in reality, during those times, for ones that have conditioned themselves to think like that so they can move on,
Right.
it functions. But it doesn't mean when they're in their own space, in their own mind by themselves,
Mm.
those are not
Or
over.
even in their unconscious mind
Yeah.
in ways that they're not even aware of, and it's
Correct.
affecting their everyday
Exactly.
life.
So nurses do have significant PTSDs.
Mm-hmm.
We get to see a lot of things and do a lot of things. And as much as we are almost going to the next,
Yeah.
there's these layers of trauma, secondary trauma that's just adding and adding and
Mm-hmm.
adding and accumulative. And remember, anything that's accumulative is just toxic and
Mm-hmm.
it doesn't change over time easily. It
Yeah.
takes time to shed those aspects of things that keeps you hostage. But we are accumulating them every day we work.
Right.
And we are almost learning how to put them in compartment.
Yeah, I think where a lot of us have trouble is the same tools that we use for coping
Yeah.
in that moment, because bed 11 now needs a turkey sandwich.
Yeah.
So the same tools that I use to go to the next in that moment are not the same tools that I need to use later to heal.
No.
But I think we just take those tools because, hey, that
Immediate
wall
support.
provided an immediate support. That wall provided me immediate protection. That
Mm.
wall made me feel stronger than I am in the
Correct.
moment, or
Correct.
as strong as I think I'm supposed to be.
Correct.
And so I want to take that away with me later
Yeah.
and carry that into some other place.
Correct.
And coping is not healing.
Correct.
And so we think that as long as we can keep going,
Mhm.
as long as we can keep coping,
Mhm.
we're fine.
Correct.
Right?
But
But we're not fine.
We're not, because nobody's going back and saying, how did you feel with that last incident?
But I noticed too, even when they are, we're so conditioned. We don't even like, it's like, I mean, that sucked, but I feel okay. You know, we can't get into the long
Fear.
like term of it, because
Conditioning fear, your job risk, right? If you truly express to your boss how you just felt, how that code just ran, or how that person just died, or what you felt, any aspect of just not happy about it, what is the nature of what would be that conversation per se?
Yeah.
Isolation?
Yeah.
Minimized?
You think that it's gonna go that way, and I think another thing is like, once I open that bottle, it's not just gonna be about this last thing.
It's gonna be about
It's
all
gonna
the
remind
other
me of
ones.
the other thing and the other thing and the other
Yeah.
thing and the other thing,
Yeah.
and all the things that. And I
Yeah.
think too, like, we all process information differently. For me, I'm very auditory. Like, I don't go lay in my bed at night and see the images,
Correct.
but I hear
You hear it.
everything. I'll rehear situations over and over and over
Yeah.
in my head, and I'm laying there and I'm like, yeah. Like, I am having an acute onset of post-traumatic stress from this thing that happened years ago, or this thing that happened yesterday, or whatever. And it's like the setting for all of that to be processed through is not in the hospital right there at the bedside.
Yeah.
It's not when that boss comes out and says, like, they were doting yesterday when I was assaulted. Are you okay? Can I get you anything? Do you want to step off the floor? Well, if I step off the floor, I know I'm just gonna have to step back on. Like if I
Your
like
work is still gonna be left
right, if I
undone.
step off the honestly,
Yeah.
if a manager is saying, "Hey, would you like to go off the floor for 30 minutes?" All I'm thinking in my head is
Who's
that's going to
taking
be
care of
30 minutes of work that I'm going to have to catch up on when I come back because you
nobody's
haven't been at the bedside in a hot second and you're
exactly.
not going to be able to
Two,
do the tasks that I need to get done right
oh,
now.
the
So it's just going to set me
quality,
behind.
right? Because
Yeah.
no practice means you're kind of a little rusty. So
Yeah,
we were like, we don't
exactly.
trust you.
Exactly.
Don't touch our
There's
patient.
no trust. There's no trust. I'm like they're like, yeah, I'll stand here for
No,
20
no,
minutes.
no.
And I'm like, no,
No.
you exactly. You will stand there for 20 minutes. And I won't have anything.
They're like, can I help you? No, just give me a
No,
scrub
you
to go. Because
cannot.
why?
Right.
We value what they do. Don't get
Right.
us wrong.
No,
But
no,
if
no.
they have now been in patient care,
Right.
we're
It's-
like, do not
it's
touch
different.
our patient.
I'm like, no.
Because
I would gladly
yeah,
skip a lunch
Yeah.
to be able to get out on time at
Yes.
night
Yes.
and not get back then hand over my patients for 30 minutes to somebody who won't be able to do what I do.
But it's exactly, and
Yeah.
there's an aspect of just personal accountability we all have.
Mhm.
How do I turn over my patient to the next nurse? There's value. There's anything. We get dopamine surge when we felt we worked so hard,
Yeah.
and we turning over a patient that's more stable than where we found them.
Yeah.
That is like the hugest dopamine boost we
It's
get.
true.
But the last thing you want is when you come back to your shift the next day, all your hard work looks like it's
Undone.
went down, and you can almost try to now
Yeah.
figure out, now I'm starting back from scratch.
Right.
So there's layers of what mental health impact for
Yeah.
what we do. And
Yeah.
it's one that we now just walk through life as normal, but it's never normal.
Right.
It's conditioning.
It's not normal, and I see it played out in other areas of my life because like okay, so if I'm 12 hours in an ER, my mindset is think worst case scenario. Think worst case scenario. You come in like literally yesterday a lady came in holding a bucket. She was a little gray. She was throwing up and I just looked at her and I was like, she has a brain bleed. Like she's gonna get a CAT scan. And
Yeah.
she did. She had a brain bleed. But that's how you're conditioned to
Yeah.
think worst case scenario. So then take that all the way into my personal life
Mhm.
and the guy you're dating doesn't text you back for 2 hours, you start thinking worst case scenario. You
Yes.
take that into, I don't know where my kids are. I haven't heard from, they're with their dad or I haven't heard from them. You start thinking worst case scenario.
Exactly.
And so you bring all of these skills and they're all intermingled and we think we're so good at compartmentalizing. We think we're so good at keeping it all separated. And it's not possible.
It's not possible. Every
Without
human,
due process, it's not possible.
it's just not, because you adding more to your cup, and the cup itself has not been emptied. It's not been washed. It's not been cleaned. It's not been sterilized. So you just adding more. It's overflowing. So which means eventually it just overflows, and you cannot pick it up anymore. You cannot put it back in, and you cannot cap it up anymore. And that's what happens.
Right.
A lot of us are able to tap into some aspect of wellness, whether it's through friends and family. But we are not going to go find a counselor or therapist and be like, I need to sit and just process this aspect of what I do as a career that actually exposes me to all of these trauma and all of these anxieties and all of these PTSDs. Because the minute we do that, now they get to say, oh, she has a mental health problems. Does she have other problems we need to look into? So now there's that stigma that
Yeah.
prevents us from truly just seeking out what
Yeah.
is just a normal aspect of wellness.
Right. And even talking about substance abuse with one another. It raises people's whatever. One of the nurses was saying it got out of hand last year.
Mhm.
Like, okay, like, all right, so let's talk about that. But we can't tell anybody because I might be unfit for work and I might be on this and I
Yeah.
might be, and I can't. And so it's like you feel this pressure
Yeah.
to not be able to be human. There's a really good book. It's called, oh my gosh, guys. It's the first podcast ever.
I'm going to fix this because my eyes have been on the whole time. Sorry.
Let's fix
Okay.
it. Thank you, wifey. There's a good book. It's called A Long Walk Out of the Woods. And it's
You mentioned that
yeah.
to me. Yeah.
It's about a physician who struggled. He was an alcoholic.
Mhm.
And even after recovery for many years, multiple jobs would not take him. I mean, this is a
Mhm.
pediatric oncologist, very well renowned with where he came from,
Mhm.
struggled with suicidal ideation. And there's a part in the book where he talks about when he goes to see his primary care provider, and he tells his primary care provider, I want to go in to a rehab.
Rehab. He says, "What's that going to do to your profession and
And
your
he looks
career?"
at him and he says, are you really sure you want to do
Do
that?
that. Yeah. Yeah.
And the guy was like, this is literally the day before he's
Yeah.
gone to see his primary care physician. He's in the woods,
Mhm.
drunk out of his mind,
Mhm.
and he's about to overdose on the bottle of antipsychotic medication that he has.
Mhm.
And he decides not to, and he decides to go get help instead. And he's telling his primary care physician, I need help,
Yeah.
or I'm going to die. Like,
Correct.
I'm going to commit suicide. My
Crying for help.
life
Yeah.
is going to no longer exist.
Yeah.
And the first question that physician asks him is, are you sure you want to do that? Like,
Mhm.
with the understanding of, don't you know that this will do to your reputation?
Yeah. In your career.
So, like, your career in medicine
Yeah.
is more important than possibly your very life. I mean, we just saw it in the Olympics, right? With Simone Biles. Like, your value in performance.
Yeah.
It's such an American, like, pervasive mindset.
Yeah.
Yeah. And so it's like, at what point are we valuing the industry, like everything, healthcare included, is so industrialized to the point where it excludes humanity?
Yeah.
A girl's gymnastic capabilities
Yeah.
are so industrialized and capitalized upon
Yeah.
to the point where it excludes her humanity or her worth and value as a person.
Correct.
And so this is a
she's
mindset
not meant
that
to
is
be
just like,
broken. Mind you, she's been broken many times because of herself, but none of us,
But I
we've
don't-
been broken as nurses
Yeah.
many times, but we're not allowed to almost
No.
now say we need help.
Nope. The world doesn't want to hear about that part.
No. So, but that's the thing. Healthcare
Right.
providers are screaming, we need help, we need support, we need
Right.
wellness.
We need.
But look at how it works, though. We are the ones that are giving wellness, and we've cried for years saying we need all of these. But when we have somebody that's a celebrity talks about it, it makes the news.
Mhm.
So I'm still trying to put my mind around that,
Yeah.
right?
Yeah.
Because
That's good insight, though.
at the end of the day, it's just an aspect of where you get to kind of step back and say, does it even matter when there's voices saying we need help that actually gives wellness, but we saying we also need wellness?
Mhm.
Or is it just, I don't know.
I don't
don't know.
think any of it matters unless it makes money. I'm to the place in healthcare now where I really have come to the point where it's like, really, like, truly, at the end of the day, hey guys, we're really short staffed today. You're gonna have 2 zones, so you'll have 8 patients, and you're gonna have this and this and that. And also, really quickly before we get started, our Press Ganey scores are at 60%. Our patient satisfaction is really low.
The front
So,
of the
like,
hospital needs a facelift.
yeah. So what are we even talking about? Because
Yeah.
how are we even talking about patient satisfaction scores
Yeah.
without talking about appropriate staffing?
Or just the provider satisfaction scores in wellness score.
And we're not even talking about that.
Exactly.
That's not getting like
Exactly.
there's no. Where do I get to fill out the survey that says my
Exactly.
job satisfaction?
But that's the
score?
thing. I've never
Yeah.
truly seen the survey, by
No.
the way.
No.
Have
no,
you?
No. 11 years in a hospital, in an acute
When
care
you
hospital.
post this
never.
video, you need to put a poll for the number of nurses that have participated in a press Ganey that talks about satisfaction.
He talks about their own satisfaction.
Their own. I've
Okay.
never seen it.
Is it the same? Like, remember they would send out those, like, okay. Remember those questionnaires we would get, and they're like, how do you like to receive recognition? Blah, blah, blah.
Unless maybe I just ignored it because it's not going to make any difference. So I feel it. I don't know.
Like, if you
I
participate.
don't remember I've seen it.
I don't know. But anyway.
That would be a good question to ask.
Yeah.
You know it.
That is a good question.
Darrell, let's get back on it.
We're going to edit
but
that
yeah,
part out, dude.
I know, right? Please. Because I'm like, what? But you're right, though. We are conditioned to say these are the standards that we need to meet. Patient satisfaction, public opinions. What else?
But like patient satisfaction, we could park there for about 2 months because when you talk about patient satisfaction, what came out of that 10 years ago was pain management. No patient was ever satisfied with pain management.
And we
So then we
created a
added
what?
we added pain as a vital sign.
And we
And we
created what?
created an opioid epidemic
Epidemic.
at the mercy of patient satisfaction.
Correct.
And it's like, what are we doing? We
Correct.
are allowing the
Correct.
satisfaction of, so it's the reverse business. It's like, as opposed to me as a provider saying, this is what's best for you. You came to me for
Correct.
care. You came to me for my expertise. You
Correct.
came to me for my knowledge. I am now allowing you as the patient to drive this entire exchange.
Correct.
Because the healthcare industry that owns me will have my ass if you don't give me a good survey.
Correct. But think about it too. No matter what we have done, even though we are the drivers of healthcare, we've always given patients the choices, the options. But remember what we do great? We educate.
Right.
We do not have those times anymore.
We don't have time to educate, but we also don't have the autonomy to say,
Yes.
no, I don't think prescribing a narcotic for your pain is what's best for you.
We're not allowed to say no.
We're not allowed to say no.
But that's in every aspect of what we do. We are not allowed to say no.
That's true.
We're supposed to get up and do what's been told to do and do it at the highest of our profession, even with no support. Even when we are drowning, even when we're crying for help, we are still supposed to show and do the work that needs to be done.
But I think that the focus, as opposed to it being on better, that's a really loud sound, as opposed to it being on better patient outcomes, is on the perception that the patient has of their experience.
But has it really been truly a great patient outcomes?
Right.
It hasn't been.
It hasn't, and it's, the focus has been on, did the patient feel like they got what they wanted or needed? But it's actually produced neither. We've produced a bunch of entitled patients that never feel satisfied and really poor patient outcomes.
And also increase their addictions, where a lot of them did not even have it. But yet we were just pushing aspect of what we think the perceived notion has to be for what their satisfaction is. But that's the thing. It's all subjective.
Yeah.
Right? Can we step back and be able to use more objectivity with what we do?
Like, are we allowed to?
No, we're not.
Yeah.
Because when we do tell patients no, we get lawsuits.
Right.
And when we do sometimes do what they said we need to do, not all the time, we also do get lawsuits. When you have providers that get to tell a patient no, they're not favorable. When you tell patients that sometimes mental health starts with you trying to go back and regain what is your sleep, your nutrition, your hydration, your exercise, and your cognitive reconstruction, people don't have time. Nobody wants to hear that. It's too much work.
Yeah. Yeah.
And sometimes it's so accumulative that these little basic things that holds people at a stability level does not even work anymore. So now we have to escalate what is the treatment.
Yeah.
So there's just layers of how the system has just been a disservice to every person.
Right.
From the education of what we need to be doing from day one to maintain health, to the fact that our professions do not give us the benefit of being able to truly enjoy what we do. We are almost on autopilot, right? We go in, we do what we need to do. We work hard. I always stress that. There's not a healthcare person or provider that does not work hard. But do you almost work out of there feeling what you did today was enough?
Never. I almost never come home feeling like all the loose ends were tied, all of the things that I wanted to get done was done, and the connections that I wanted to make were made. And then it's just like you, at some point along the way in the past, I've just silently accepted that.
Yeah, but that's the conditioning, right? You just go in and you do your job, and now you don't feel the need to be almost the change maker anymore, because most likely when you made your first noise, your first change, it was received but not received. And
it was like, oh, you're a new grad. You'll get used to it.
You get used to it.
You'll
It'll
get
pass
used to
soon.
it because a new grad isn't conditioned. A new grad isn't conditioned yet to be like, a new grad comes in and they're like, oh my God. So I was just reading an article the other day that new grads receive the most bullying from other nurses, right?
Yeah.
And I was wondering if that it wasn't like that they received the most bullying.
Yeah.
It's just that they were introduced into a toxic ass culture that they've never experienced
Yeah.
before, and
Yeah.
they interpret it as bullying
Yeah.
because they're so fresh.
Yeah.
They haven't been harmed in the way that we've been harmed yet.
Yeah.
And so they're coming in and they're like, holy shit, this is not okay. Like, this is not right. This is not, and it's like 3 years,
Yeah.
you'll be fine.
I had somebody says, you think you're gonna change the world. Let me just give you a few more years and let me see where you feel about that or how you feel about that. I didn't get it then. I was like, what is she talking about?
Mhm.
Um,
Get it now.
but that's the type of narrative you
Yeah.
get when you enter. And it's sometimes we almost at that point in time be like, oh, she's mean. But it's an aspect of lost hope
Right.
and feeling hopeless that makes a person who would have been one that empowered you
Right.
to almost not empower you anymore, saying this is a loose war or loose battle. You will do great, but you're not going to get to your optimum potential of what you are now walking into. Because remember, when we walked into healthcare and the bedside, yes, we were scared. We were scared about everything we did, but we were going to save the world one patient at a time. And even then, we were going to be part of these huge communities to make changes.
Yeah.
And then you realize being part of all of that was not moving anything forward. So what do? You start to take a back seat.
Yeah.
You start to focus on reserving your energy.
Yeah.
You start to focus on, I'm going to come in and do the best I can do so I can
Yeah.
walk home and sleep at
Yeah.
night.
Yep.
But the aspect of the change you wanted, the things you wanted to
The
do,
change
it just
agent that they talk about when you're getting your bachelor's degree. You're an agent of change.
changed. Yeah. How many of us,
Are we?
literally, you almost saw the sparkles going off. And you're
Yeah.
like,
And then it's like, but even in that, even in the educative system, you're almost conditioned to say, like, you're a change agent if you publish an article.
yeah.
And I'm like, okay, there's
Yeah.
there's a million articles
That is
out there.
and none of us get
And
to
none
really
of them
touch
is
it.
actually conveying into
Any.
practice.
Any.
None of it is actually bearing influence on what's going on in healthcare.
None. All superficial.
Yeah.
All does not tell the deep dark secret of what it is like to be in the healthcare industry or the impact it has on our patients and us and the lack of support. So when we talk about shortage, I think before I even became a nurse, there was a talk of shortage. But actually, when you look at the numbers and statistics of nurses, there's a lot of us. We just
There's not a
exit.
shortage. There's a shortage at the bedside.
Yeah.
And that's the difference. And actually, in the last 3 years, nurses have left the bedside at a rate that has been unprecedented at any other time in history.
But this is what they did, though. And it's so funny. So nurses are exiting, but you are taking what is, instead of doing proper staffing that brings more satisfaction, you get to say, I'll give you a bonus to come and work a worse difficult shift understaffed. The logic is not there.
The logic is not there. Like, so we've been, during the pandemic, we were working, and then they're like, we're going to have travelers come in.
Yeah.
Okay. And this is why nurses are going to traveling nurses. Like, traveling nursing makes money.
Yeah.
And I'm going like, hello, if you were willing to pay your faithful, loyal staff
And recruit more locally.
that much money,
Yeah.
you wouldn't need travelers.
Exactly.
And then you'd have people that know what the hell they're doing because they're in the same location every day.
In the same system every day.
Like-
and remember, travelers, they bring value.
They bring value, but
not
they
the same value as for somebody who knows the workings of that
Yeah.
corporation.
and
right?
feels like, I mean, at least for me, I go to work and I feel like I'm caring for my community.
Yeah.
As a traveler, like, I'm doing a job and
I'm
I'm getting
passing
money.
through.
Yeah.
I'm
Yeah.
passing through. So that what would have been the true value assigned doesn't mean they're not working hard, but they're not going to be the ones that's saying, this is not working
Right.
correctly. Can we
Right,
fix
right,
it?
right. No,
They're
no.
saying I'm
They're
passing
getting a
through.
job and they're going.
Exactly.
Yeah.
So healthcare as in general, burned out is an understatement. Aspect of how the industry has managed to monopolize what is the financial gain is an understatement.
Yeah.
But the question gets to be, what do we do as healthcare providers to start advocating for ourselves so we can
Right.
gain some wellness in the spaces that we really value being in, right?
Right.
So we need to demand they have to be trying to really truly have what will be a mental health counseling. But yeah, let's just start with a basic. Find a way to make sure people get lunch breaks. Start with that basic. A true break.
A true break.
A true break.
Yeah. I mean, yeah. That's
Find a way to give extended care or extended leave to providers that have experienced what is a traumatic shift.
Yeah.
We go through traumatic shift almost once a week. And what
Mhm.
happens? We just go home and come back and add more.
Yeah.
Give them time to leave and time to well, and even maybe allow them to now visit what is a paid service for counselors and therapists to process that. And they can come back with some aspect of rejuvenation.
Hmm. But it needs to be outside the setting of work because
Yeah.
that none of that is getting dealt with right then and there.
Well, it should be in a way. If proper staffing, if wellness for the providers or the caregiver was an impact,
Mm-hmm.
when you suffer a code, that should be almost where they get to say, "You're done for today. Let's move somebody in who can kind of assume your shift." So you can now spend time with the person. That used to be, at least back in 2006 when I started working, there was a tiny hospital I worked for, and they did that. But I guarantee you they were not making money in those aspects because
No.
remember, all of them, there's a potential for financial gain, right?
Right.
Lots of financial gain when you do that. But they pulled you aside to say, take care of the family, process for the family, be there with the family. So as much as I was not the one crying and wallowing, because I learned over time you cannot do that.
Right.
You cannot be crying as hard over the family who's losing.
Right.
But you can sit quietly, listen quietly, be present
Be
for
present
them, but
in
you
the-
also present for yourself.
Yeah. Yeah.
But at the end of the day, we got to go back to that. Let them pull us away. Let them have us focus on that one person. Let them bring a second person that's now taking your assignment so you can process. That's actually good for your wellness.
It's good for your wellness. I can't even imagine them doing. I can't even imagine them doing it.
But that's because we're conditioned to saying it's not possible.
I feel that the only way that healthcare is going to change is when all of us walk away, and we're all just like, "You want to play this game? You can do it all by yourself."
No. It's guilt. You would not be able to
It's
walk
true.
away.
It's true. Well, you definitely can't walk away in the middle of a shift.
No.
You definitely, but like,
You will have significant guilt that will eat you inside out because at the core of you being a person is what?
I'm a
Healthcare giver.
I'm
You
a-
are
yeah,
a giver.
I'm a nurse.
No matter where
At
you go.
at the end of the day, I'm a nurse. I get that. I really do.
We can't.
But I think also beyond guilt is a component. Another component is the rush, the thrill. There's a lot of people that won't walk away because of
the sense of duty,
the sense of like
the moral compass. When
there's
we
that.
enter healthcare, we did not just walk into healthcare. A lot of us came in with that aspect of moral compass that we felt our hands and our care brings wellness to the mass population.
But my hands aren't well, and so I can't make you well.
We
when
all
I'm not
know
well.
that.
Yeah.
But remember, we are also providing care even when our hands are still not well. That's why we have lots of suicides. That's why we have lots of addiction. Because we are still saying we're going to put those part of us back, and we are now going to just give what we don't have to give.
We have to do an episode on addiction.
It's a huge
especially for nurse anesthetists. Did you know there's a whole entire population of nurse anesthetists are addicted to propofol? They're going home with IVs in their ankles.
Yeah.
And like, I'm going like, why aren't we talking about this? Why aren't we
The
talking about
thing
this?
about that is sometimes I get scared about if there's not true statistics.
There
How
are.
do you?
There really are.
Because I would love to make sure we, no matter what we do as nurses, especially when we have platform, is always to put us higher, right? So we want to give it in a way that we can still talk about addiction, but talk about what is the condition.
The conditioning leading up to that.
And it's also trauma though.
It's trauma.
That's why surgeons are also one of the number one suiciders, right? You opening, you cutting, you seeing blood.
Surgeons and ER physicians
Yeah.
have the highest suicide rates in the United States.
And nurse anesthetist has the highest addiction and suicide, by the way. We've seen a lot of them die. Because remember though, you're going through trauma all day. Body's been opened, skin been burnt. As much as we think it's just a professional aspect of processing, it's not. And this video is off now, right?
Is it off? Are we off? Or are we still rolling? Oh, we're still rolling. It's okay. Like when
you get the chance, there's this aspect of me kind of advocating for nurses and nurse practitioners.
Yeah,
chop it up. But no,
don't chop it off.
No, we can't. No, because I talk about we have to lift our profession up. Anyways,
we do have to lift our profession up, and it's important that we give this information in a way that isn't like, nurses are actually shitty and they're not as great as you think they are, but we give it
Correct.
in a way that like we are desperately
We
struggling
are.
and we are still giving 1000%
Correct.
of what we have
Yeah.
while we at the sacrifice of ourselves,
Yeah.
literally.
So I can tell you there was an aspect of just coming from a traumatic background and smelling burnt flesh.
Yes.
And when I actually had my first orientation in the OR for cardiovascular open chest, open hearts for
Mm.
pediatrics, and when that cauterized actually touched the skin, and even though we had face mask on, that
Mm.
smell tapped me back.
Triggered. Yeah.
So don't get me wrong. Some people can see blood all day and they just, oh, it's just blood. Just like we get to see death all day, it's like another death. Does not mean it's not an exposure that leaves an aspect of trauma
Mhm.
or negative emotions
Mhm.
or aspect of just poor. We're not processing it.
Yeah.
It is profession, but it doesn't mean it doesn't come at an impact of your wellness. So I do not know what will be the factor behind what makes surgeons, nurse anesthetists kind of develop these problems,
Right.
right? But you can almost assume that what we get to be doing on a daily basis may have a potential additive cost to it.
Yeah. Yeah.
So
It isn't normal.
it's not normal.
I think because it's a controlled environment, you almost want to tell yourself it's normal or it's okay. But
It's a cult.
it's controlled to be in
I
an
just,
OR and cut somebody open.
yeah,
That's controlled, but that's not normal.
it's not normal.
It's
And
not it's
over
not what ever other people are doing all day.
you almost get to imagine what are their
Yeah.
dreams like,
Yeah.
what are their processing like,
Yeah.
what are their smells like. Just like you say, when you hear certain sounds,
Yep.
you hold on to the sounds, but now you walk in and enjoying life and you hearing those sounds and
Yep.
you turning around, activating
Yep.
your sympathetic system. Like, remember first year of nursing, you would dream about the beeps and the alarms and
Yes.
you wake up sweating and shaking.
Like you're missing
You're
something.
missing
I'm
something.
missing something.
And then over time, what happens? Those dreams disappear.
Over time, what happens? You barely even hear the alarms when you're at work.
Exactly. And before that, those noises were so loud and
Yep.
so
Stimulating.
stimulating.
Yeah.
But what do we do now? We are 100% hyper focused. You can almost see when your client or your patient is about to become something other than well, right? You're looking at all these factors.
Yeah.
The thought process you're talking about, you processing, over analyzing. Experience, exposure, lived experience allows you to see when you feel that patient is going to need it, or dopamine or norepinephrine drip or any aspect, because you see the trend, you see the signs, you see their coloring, you feel their temperature.
Yeah.
You are almost programmed to see all the
Yeah.
worst case that can happen, and now you've actually seen it 100 times down and you're calling for help, and
Yep.
sometimes it doesn't happen on time.
Right. Right.
So there's an aspect that healthcare doesn't leave us with much space for wellness. And walking away would not be one that really solves any of us, because as much as it sounds great, moral compass would
I
not
don't
allow
I
it.
don't know. I don't think that the industry itself is going to allow for change until and unless we do something drastic.
We did a big
Because
march
they
back.
can't a big
What year
march.
was that?
A big march.
Yes, we
They
did.
can't. Oh, great. But we marched. We
That was the closest we could do.
we exhausted our legs for an entire day is what we did. We can't. I don't think that they will do anything differently. They can't function without us.
100%
They can't
true.
function without us.
100% so.
And that needs to be well
So
known.
we all know, we've always said it. If nurses and nursing as a profession were unified in our views of what the change needs to be, we will be a force that no corporations can reckon with.
Right.
But we're not.
I think unions have tried to accomplish this over time.
That's why they've been eliminated.
And they've
in
been
most
eliminated.
hospitals.
And in most hospitals, when you get hired, you have to sign an agreement that you will not join a union.
Exactly. Nobody knows that.
Nobody knows it, but it's in the contract.
It's in the contract. But think about it.
Yeah.
As a unified voice, we are the largest. We can impact. But as a separated, individualized, manipulated mindset, we cannot mobilize
Yeah.
because there will always be some of us that may feel strongly about it,
Right.
and there'll be some of us that would not be able to kind of even have any sense of idea or even feelings around it.
Yeah. It's interesting. Like, you talk about this stuff to a new grad nurse, they almost look at you like, "Are we allowed to talk about this?
No,
Like, are you allowed to say that?
you conditioned from day one.
Are you allowed to?" Like, no, I'm going on break. I don't know what you need to do to handle that, but I'm gonna go ahead and go. And the new grad nurse is like, "You can do that."
You can do that,
Like, and it's
Yeah.
like, yeah.
But even then, you're not going on break. You
No.
have your phone with you
You
in the
always have
bathroom.
your
It's ringing. You're answering it in the bathroom.
It's true.
So we
It's
do
true.
we do have power, but just because we have power does not mean we're using it correctly. And just because we have power doesn't mean everybody wants to use it in the first place. And for some of us, remember, part of misery or part of life is some people are just comfortable in the space they are in, even when it's actually fire and smoke going off. They're comfortable just not moving. So
It's
how do you
interesting.
get those collective to
How do
come
you get
in
the
and say,
collective to
this
come
is what we want to change? The
Yeah.
march was the beginning, but even then, the next day, a lot of us ran right back to the bedside, right?
Yeah.
But even
What are we
then, there
gonna
was
do?
a lot of us that refused to attend that march because our patient depend on us.
Mhm.
So impact on moral compacts, duty to the profession, duty to
Your
yourself.
own, yeah.
Yeah, there's so many
Calling.
layers of it. Correct. So I don't know. I don't know the solution, but all I know is let's start giving our nurses and healthcare provider breaks. Let's start giving proper staffing.
Proper staffing is like huge
Huge.
because we can't even talk about breaks if we don't have staff to cover it.
Exactly.
Yeah.
And let's
Staffing.
stop paying money to higher premium of providers that are passing through and use that to actually
build up
your local staff and your current staff and empower them to do the work they're already doing with just limited support.
Yeah.
We all love what we do, but we also all walk away eventually saying we're done. Or the ones that don't walk away, they have all the aspect of just
What's always interesting to me is like the money is there. The money is there.
doesn't bring wellness.
But I'm saying like the money to have
for
more
healthcare?
staff
Oh,
and
yeah.
healthcare, it's there.
Oh yeah,
Like
it's there.
our CEO, your fingers.
Sorry.
Our CEO made a $3 million bonus in 2020.
Look at the insurance company. Look at their CEOs and their bonuses.
The money is there
Mhm.
to be able to pay adequate amounts of people to be at the bedside.
We are the U.S. spends so much money on healthcare than any other culture.
Right. We're number 43 in the world.
Yeah. 43? I thought we may even more higher than that.
No.
In terms of spending?
No. In terms of quality.
Oh, quality.
We're down to 43. Yeah.
I was about to say, I thought we were like on the highest aspect of healthcare expense and cost for
Highest
healthcare. But yet, when it comes to patient outcome,
Right.
43.
Yep.
Correct.
Highest outcome of expense for number 43 in patient
Outcomes or just
results. Yes, like the World Organization, it talks about women's health, children's health, fertility, whatever.
We see more than third world countries, which is surprising, right? But there's money. There's money, which means the aspect of shortchanging any aspect of what becomes the environment we work in is one that how does it get to be explained?
Yeah.
How do they get to take accountability for it? How do we ask them for accountability? But walking away would not work because there's just so many of us that have an aspect for the duty for.
I just feel like we have to take it back. It's just a matter of how.
But we never had it. We never had it.
We
Taking
never
something
had it.
back is where you actually had it.
We have to take it. Then we just have to take it.
We
period.
have always fought for our space in healthcare from day one. The stories around the lady with the lamp at night. She had to fight to be in that space to say, I am capable of taking care of patients. We've continued to still fight to just be able to say we do good work and we demand these conditions. We continue to fight to occupy space, but that is actually the aspect of being female or just female-dominated
female-saturated careers.
Exactly, right? We're always fighting to occupy space in something, but nursing is not any different than what we still continue to fight for.
That's interesting. We're just talking now, June. I think we're good.
I think so.
I think we're done for we're not going to solve all this today. This is going to be an
Well, you can
ongoing.
close it up. You can close it up by us now talking about what we can do truly as a healthcare providers for temporary
I don't have the
measures.
answer for that.
Just just temporary.
I don't know.
So do a closure because if not, this is gonna be almost like you stop short and that's it.
Well, I'll end it. I what I don't want is uh band-aid solution. Like I don't want to do that. So I'm just going to end it. The problems are too complex to be like
They are
the first thing we
complex,
need to
but
do is no, I'm not
no,
doing
but
that.
I mean part of
I'm
that
not.
is just wellness, right?
Well,
So we can say what are nurses and providers doing outside when they come home. If the system cannot give you wellness, what can you do when you come home?
get a fucking therapist.
Well, we
That's what
cannot
you
get a
do.
fucking therapist because remember we have stereotypes, right? Especially if we're using our insurance, it's
I
not
think
reportable.
how I want to wrap it up is to just say, um, if like you're not alone, you're not alone in this. Like
No,
we're not gonna sit here on podcast number one and say that I have one solution for you, but just understand that this is an experience that is felt by all healthcare providers
yeah,
and clinical bedside staff. I think it's important to just establish that camaraderie and hope that that leads toward unity within our profession and
correct.
within our because what I'd like to get to with this is some answers um, and hopefully shared experiences and things like that will lead to that.
And also, hopefully, you can encourage them to seek out help regardless of the stigma.
Mm-hmm. Yeah, there shouldn't be a stigma because we're all
There is
dealing
a
with the same thing.
there is a stigma.
Oh, I know there is, but I'm saying that's why there shouldn't be. Like to say like, oh, this shouldn't like you should be ashamed that you're going through this. Well, no, we're not. We're gonna pull the shame right off the top of this because we're literally all going through this.
But that's the thing, though. How many people do you know when they start talking about mental health, you get the person says we're all going through it. Exactly,
Yeah.
right? You see body changes,
Mhm.
conversation change, because we almost isolate.
We do. Mental health causes you to isolate. Um, so that's all I want to do with this is just to say like, you're not going through this by yourself.
No, we're not. We do know where the problems are. We just do not know how to solve them.
Exactly. So thank you for joining because we know where the problems are. We've been in the industry for a long time
Yeah,
and we can all feel what isn't right inside of us.
yeah.
But I do want to create something where we can collectively come up with solutions.
It's possible. It's just one that whatever the solution is gets to be one the mass population feels it morally supports them not going against what is there. You will move more people when we feel we're all working towards what we feel is the better for. Because
Mm.
as nurses, that's way, right? We're always for the better of our patients,
Right.
our community. So we will gain more mobilization when we feel we have a solution that moves us in that direction without impacting the main people we came out to work for
Right.
or serve.
Right.
And it's possible. It's just how do you go about it?
Mm-hmm.
Mind you, though, some of the reason why you have more nurse practitioners in full practice states opening their own and taking time now, that's one of the
Yeah.
change.
Yeah.
But it doesn't serve the mass population. It serves specific niches who can afford it.
That's true.
So that's a disservice in general, but that's how they're
That's true.
trying to reach and connect
Yeah.
or change. So there's layers of these things.
Mm-hmm. Yeah. Yeah.
So
Well, Umu, I like it.
I don't know how it's going to turn, but I hope you guys have some good footage.
We're gonna have more conversations. We're gonna talk and talk and talk,
Yeah.
and people are gonna comment, and I'm gonna read those comments, and I'm gonna be like, "That's a good thought. That's a good this. That's a good that. I'm gonna talk about this. I'm gonna research that."
Yeah.
And we're just gonna keep talking
Yeah.
because ultimately, influence changes culture.
Yeah.
Influence changes culture. We're just gonna keep talking And people consume social media. They
Yeah.
consume it,
Yeah.
and it shapes what they believe, and
Yeah.
it shapes what they think,
Yeah.
and that shapes culture.
Yeah.
And so these types of conversations surrounding this issue and it getting to actual healthcare providers and bedside clinicians starts to reshape the way that they think. And it starts to bear influence, and they start to take what they've heard somewhere else and apply it into whatever. You do it in other areas in social media. And so you're taking something that's already a known brainwashing condition, and essentially you're brainwashing for the right reasons.
For the right reasons.
And you're changing and influencing culture.
That also comes through empowering patients to demand aspect of what they consider safe.
That's true. But this is the other key to that. Patients don't know they're unsafe.
Correct.
They come in and they're like, they 100% trust that, like, whatever med I'm pushing through the IV, they don't even ask. Whatever I'm doing, like, they 1,000 for the most part. Some every now and then somebody will be like, hey, what are you doing? Or hey, what's this for? Or whatever. But for the most part, patients don't even know
Correct.
the margin for error that exists as they lay in the bed.
And the way we can support us, the profession, getting the staffing, the support we need is by educating them, right?
Yeah.
Any aspect of journey that need a change in the US or in the world has always been you educating the direct persons that will be affected.
Yeah.
I don't know how to say the correct word.
No, that would be a good episode, actually, to talk about patient education. I'm going to write that down.
Because if you educate them, then they demand.
Because if you educate them, but I think there's been a purposeful downplay of patient education, so they are not aware of what they should be demanding.
Exactly.
Yeah.
If you see your nurse chasing tails in multiple rooms and you feel, you should be able to say, it looks like she's busy. And the more we voice that, patient satisfaction.
Patient satisfaction, but what's going to end up happening is that nurse is just going to get in trouble. It's not going to equate to anything that doesn't make money. That's what I'm saying. That's what I'm saying. I think the whole thing has to be destructured and rebuilt.
Might be.
Yeah.
You'd be surprised.
So.
You'd be surprised. This has been a wonderful topic.
I'm Julianne.
Oh, I'm Umu.
And we're done.
And we're done. And thank you for having us kind of just ramble your ears. We would love to hear your feedbacks.
Yeah. Like, comment, share. I would love to hear what you guys think, what your struggles are, what issues you think are important in healthcare, and if you have solutions or if you have ideas, would love to talk about them.
And remember, we're not experts. We're just giving personal opinions and we're hoping you guys can share the journey.
We're not experts at all. We're just two nurses talking.
Exactly.
So,
just two nurses? No, we are nurses talking.
We are We're nurses.
Exactly.
Nurses.
Not just nurses.
We're nurses talking.
Nurses talking.
So
that brings value.
It does bring value. Thank you so much.
Thank you.